you for that excellent presentation. Now I invite Dr. Soumya PP. She's working as a glaucoma consultant and phacosurgeon at Comtrust Eye Hospital, Talasheri. She'll be talking on the tipping point, decoding the lag between nerve loss and vision loss.
A very good morning to everyone. My topic of discussion is tipping point, decoding the lag between nerve loss and the vision loss. What is it? First, we have to understand what is tipping point. Why the nerve loss shows long before the vision loss. The retinal ganglion cells, as you know, and their axons begin to die early. But yet the patients continue to see normally, sometimes for years. Eventually, a point is reached where vision suddenly starts to deteriorate. This delay is known as structural functional lag, and the moment vision finally declines is called the tipping point. So this is this. Biochemical changes comes, then the structural changes comes, then the functional changes comes. Why does this lag happen? What is the cause? There are many causes for this redundancy in the visual system. As you know, the eye contains about 1 to 1.2 million optic nerves, and you don't need all these for the normal vision. So in the earlier loss, the system compensates for it, and the later nerve loss, the compensation fails and the vision loss emerges. And think of it as a losing of internet bandwidth. You don't notice until you have crossed a threshold. There is also a functional reserve, that is, the brain is remarkably adaptable, and the surviving neurons increase their activity when there is some damage, and the neuronal circuits reorganize to maintain the function. This reserve capacity marks the earlier damage as well. So there is also a measurement mismatch as well. We use different tools to measure the structure and function. As Manju said, we can use OCT, visual field test, etc. So this comes into play here. The OCT detects tiny structural changes in the nerve fiber layer in the earliest stages. Visual field tests are noisy and slow to changes. So the structural changes can be visible years before the functional loss is measurable. There is as well a non-linear relationship between the nerve loss as well as the vision loss. Studies suggest that up to 25 to 40% of the nerve fibers may be lost before the standard clinical tests detect the vision loss. After the tipping point, suddenly the vision declines rapidly with additional nerve loss. This is why early detection is crucial. So in short, what is tipping point? It is a glaucoma refers to a critical threshold of structural nerve damage that once crossed leads to a rapid decline and clinically detectable loss of functional vision. That is visual field defects. Identifying this point is primarily done through a combination of the structural test as well as the functional visual test with current technology allowing detection of structural changes before the functional changes is apparent. What are the key methods? As I told you earlier, the OCT. In this imaging technology is crucial for detecting the structural changes, which includes the retinal nerve fiber layer thickness as well as the ganglion cell inner plexiform layer thickness. The tipping point threshold studies have identified approximately average RNFL thickness of 75 micrometers as a common tipping point. When the average RNFL thickness falls to this level, representing up to 17% loss of the age-matched normal value, visual loss becomes more apparent. How does the OCT indicate the tipping point? It detects the earliest structural damage. OCT can identify and quantify damages to the RNFL and structure like ganglion cell often before the patient even notices it and shows a lag in the function. There is a period in the OCT can show structural damage, but visual fields does not show any changes. That is normal results. Identifying the tipping point is very essential. And it provides a benchmark for progression. Once this tipping point is passed, the rate of visual field loss accelerates. So the OCT can help monitor this progression more effectively. There are certain limitations for this tipping point and beyond. A conflicting data is that if an RNFL is very thick or very thin, there can disconnect between the OCT and the visual field changes even around the tipping point. For example, a ceiling effect, that is very thick RNFL. In healthy eyes or a very early glaucoma, there is a large reserve of nerve fibers. Significant changes to the damage to these thousands of fibers must occur before it is detected by a standard visual field, as remaining fibers can compensate, as I told earlier. The OCT may show a thick, healthy reading, while early functional loss is just beginning to appear on a sensitive VF test. The other one is the floor effect. That is due to the very thin RNFL. In advanced glaucomas, the RNFL is severely atrophied. It approaching the floor effect where nearly all fibers are gone. And even substantial loss of this remaining fibers doesn't register. It doesn't register a significant change in already minimal OCT measurement. However, this subtle ongoing loss still translate to noticeable progression defects on visual field tests. These are the two limitations of a tipping point. So this is an example. As you can see, there is a diffuse loss of RNFS in advanced glaucoma demonstrating floor effect, and the ST would not be using a stage of disease. When an individual has an unusually thick or thin baseline measurement due to natural variation, tipping point often shifts, as I told you, in the floor effect and the ceiling effect. This highlights the importance of using both structural and functional visual tests for managing conditions like glaucoma, as neither tests tell the complete story alone. We have to use both of this. So as I told earlier, this visual field test is there, which is a checks for blind spots or area of reduced sensitivity in our vision. Earlier stages, in the early stage, visual fields often appear normal or highly variable because of visual system have redundancy. Beyond the tipping point, once the tipping point is reached, functional damage progresses more rapidly and becomes consistently detectable on this test. Then comes the guided progression analysis softwares. Both OCT and HFA devices utilize software like GPA to track changes over a time. Trend and event analysis. The GPA reports look for both gradual rates of trend changes, trend analysis, and a significant confirmed changes in a specific location, that is event analysis. A combined approach is usually needed. This is a small picture of the GPA. So identifying the tipping point helps. How does it help a clinician diagnose the glaucoma earlier, guide the treatment decisions, monitor effectively? Diagnose structural changes can show damage years before the functional loss appears on the standard visual terms, and guide the treatment. That is, more aggressive treatment, example lower target IOP may be necessary, and you can do it in a younger patients and nearing the tipping point to preserve remaining normal vision for their lifetime, and monitor effectively. That is, monitor to mild to moderate cases primarily with OCT while relying more on the visual tests in advanced cases. This is very important. There are several comparative studies for the existing methods. Several strategies have been proposed to address the individual's ocular factors in interpreting the relation between the structural and functional measurements. The compensation model incorporated various demographic variables to establish multiverse normative value with the compensated RNFL outperforming the measured RNFL. These are several studies. Montego et al. Suggested proportional change based on normative value derived from regression model, prompting progressive future studies comparing with the approaches and the proportional changes comparison and direct measurements. These are other studies that I have taken. So why understanding the tipping point matters? It helps the clinicians use it to diagnose glaucoma earlier, start treatment for the functional damage occurs, track disease progression more accurately, decide when to escalate the therapy, and how the researchers use it. It improves the biomarkers, it develops neuroprotective therapies as well, model disease progression more precisely. These are my references, and thank you.
Thank you, Dr. Soumya.